Hello, Assalamu alaikum. Can you hear me? That's fine. Very good. So I think we are already late, 10 minutes, so we can start quickly. I will go and share my screen to you and we'll start it. If you have any questions, I can take all these questions at the end. So today, our topic of discussion is bariatric surgery. It is a new field of surgery which is actually gaining a lot of popularity nowadays. In other words or layman words, we can call it a layman's word. We can call it a weight loss surgery. हाँ सर ये चलवा देंगे उसको कहेंगे उसको कह दें. We can call it a weight loss surgery as well. And we'll go through in today's lecture different types of operations which we do for weight loss, and we'll go through the indications and the complications, plus what is the rationale of the surgery and why is it important. So actually, the obesity is a big problem nowadays in current society, especially in the Western world and the Middle East, where people are quite rich and affluent, and they are eating a lot and spending very little. And you can see after surgery, you can actually reduce to half of your size. And there are a few pictures of the patients before the surgery, and this is the one, and after the surgery, the second one. The actually a lot of people are using a lot of medicines for reducing of their weight. And the one big benefit of the operation is that there is no post-op medication except few multivitamins and minerals, and rest of the medications they all go away. So we'll start with the definitions. And what is the definition of obesity? To know the definition of obesity, we need to, the scientific definition is actually depending upon the BMI. BMI, you all know, is actually body mass index. And the formula of BMI is if you divide your weight in kilograms by your height in meters square, you will get the BMI. So if somebody's weight is around 60 kg, so he would write 60 in the upper portion, and the denominator in the lower portion is the height of the person. Let's assume our height or his height is 1.5 meters. So it would be 1.5 meters square. So weight divided by height in meters square is the BMI. And the definition of obesity and overweight and morbid obesity, they all depend on the BMI. So you all can calculate your BMI and you can see where you fall. And this is for the adults, these definitions. And the normal BMI should be less than 25 and above 18.5. So between 18.5 and 24.9 is the normal BMI. And if BMI is between 25 to 30, it is called overweight. And if BMI is 30 to 35, it is class 1 obesity. And 35 to 39.9 is class 2 obesity. And more than 40 is class C or morbid obesity. And this is for the adults. For children, there is a separate chart available for the weight and height chart, and it is above 95th percentile BMI, that is called obesity. So I think you all can define obesity according to this BMI definition. Actually, normal is up to 25, overweight is up to 30, and above 30 or above is obesity, and 40 or above is morbid obesity. So is it really a big problem? I think when I came back from Western world to Pakistan, I found that this bariatric surgery operations are actually very few in number in Pakistan, but it was very common in Western world, UK, and all over the world. And this problem is actually not that common in Pakistan. Probably we are a poor country and not a lot of people are falling into this category of obesity. But it is a big problem in the West, big problem in the Middle East, and a lot of people are doing these things. So the prevalence of obesity, in if you calculate, if you see the numbers of the United States, it is increasing rapidly. And mean like around 15 million people were obese in 2001. That is quite a lot of number, and it is increasing a lot. The other issue is the obesity is the second most common cause of death in the United States after smoking. It is not the, you can not say it is the second most common cause of death, including the diseases, but it is the modifiable behavioral risk factor. I mean, you can modify, this is a behavior, eating, just like smoking is a behavior, and it is a modifiable behavior. And excessive eating or less exercise is leading to obesity, and these two behaviors can be modified. And after smoking, obesity is the second most common cause of death from a modifiable behavioral risk. And of course, these patients, they are hospitalized, they develop a lot of complications, and because of that, a lot of cost is incurred onto the hospital and health system, and that is also another aspect. So the mortality and morbidity plus cost, both are the issues, and that's the problem. So, what obesity can cause? Obesity itself can lead to type 2 diabetes. It can cause hypertension. It can cause dyslipidemia. It can cause obstructive sleep apnea, arthritis, gastroesophageal reflux disease, fatty liver, polycystic ovaries, also depression and loss of function. A lot of other conditions as well, but these are the common problems which are related to the obesity. And there is another table which shows the conditions which are associated with the obesity. And if you see on the left side, almost 3 times the risk of a normal person. If somebody is obese, they have 3 times normal risk than the normal person, risk of developing a diabetes, cholelithiasis, hypertension, dyslipidemia, insulin resistance, obstructive sleep apnea, etc., etc. And 2 to 3 times more common than the normal person, the risk of coronary heart disease, knee osteoarthritis, and gout, and all these things. Plus, also there is slightly increased risk of different cancers, especially breast cancer and uterine cancers in postmenopausal women, and colonic cancer. Also, polycystic ovary syndrome is a common thing in obese girls, and fertility problems, backache, and all these issues. So there are a lot of health problems related to the obesity. If we move forward. So what are the causes of obesity? There are many causes, but if broadly we divide the causes of obesity, we can say it can be in the genetics of a person, or it can be the behavior of that person, and also some environmental factors. So you cannot change the genetics, but the other two things can be changed. Behavior of somebody and the environmental factors are modifiable. So what environmental factors are there? Because if you see, I have this slide here. If you see the sizes of portions of meal and drinks, they are actually increasing with the passage of time. In 1954, Burger King's burger was of this size, only 200 calories. But now it is more than 300 calories. Similarly, McDonald's French fries, a small size, 200 calories. Now they have gone up to 600 calories. Similarly, if you see the Coke or Pepsi bottle, we used to drink 250 ml. Now it is 300, 500 ml. So the caloric environment is also increasing. The portion size of the meal is also increasing. So that is another factor of the environment. So one thing is established that obesity is a problem of the current world. So what are the treatment options for the obesity? Since long, there are a lot of effort is being put on to the first three treatment options. If you see this: diet, exercise, behavioral therapy. These three are were the cornerstone of the obesity treatment previously. Like a person should do a lot of dieting, they should do a lot of exercise, and they should go and see some dietitian for some behavioral changes in their eating habits and all these things. So these three were the cornerstone of the treatment. Then some drugs came up, and unfortunately, this number four was a failure, and hardly any drug came up to the rescue. And no drug is definitely a treatment for obesity. So this is out. And then the fifth option came up was a bariatric surgery, doing some kind of operation to reduce the weight. So this is the bariatric surgery. And if you see now, these three things are also quite helpful, but bariatric surgery results are definite and they help a lot of people. So we move forward, and this picture shows that a lot of people are trying very hard to reduce the weight by diet, by exercise, and everything, but it causes failure at the end. You reduce weight for some time, then gradually again you gain weight, and then you again start this cycle again: dieting, exercise, and weight loss. And then after some time, you lose some interest, or there is some other issue in your life, and then you again gain weight. So this cycle keeps on repeating and repeating, and people are actually fed up of this cycle, and they stop doing this and they become obese again. So here is the surgical treatment of obesity. So I will only touch the basics. It is a very, very new field of surgery, and not a lot of centers are doing it. It's actually a new chapter in your book. Previous editions, they had no chapter on bariatric surgery. It is, I think, in last two or three editions, this has come up. So we'll just touch the basics. And the surgical treatment of obesity is, what is the rationale of the surgery? This is most important because people ask why you want to do operation for bariatric surgery, and that's actually important. So the rationale would be, once you do dieting, your basal metabolic rate also falls down. And because of that decrease in basal metabolic rate, you regain your weight again, and your body hemostatic system, it sets its point again to the previous weight by reducing the basal metabolic rate. So dieting causes decrease in basal metabolic rate, which causes weight to return to the previous hemostatic set point again, despite all the dieting. That's the reason in the initial part of the dieting, you lose a lot of weight, but later on your BMR goes down and weight becomes up again. Number two thing is, it has been noted that this bariatric surgery, it somehow alters this mechanism, and the basal metabolic rate does not go down, and sometimes it may go up actually, and your hemostatic set point is reset, and there is definitely still you are having 25% or 20% weight loss maintenance after 20 years, which is a very, very huge success. And also the third rationale is, actually, this is also very important, that bariatric surgery leads to long-term survival benefit because it makes the quality of life of the person better. Also, it is treatment of a lot of obesity-related diseases, which I mentioned earlier: diabetes, hypertension, dyslipidemia, chronic coronary artery disease, and all these, and a lot of cancers. So bariatric surgery not only reduces weight, but it also treats these diseases, and that's why there is a long-term survival benefit. So this is the rationale of the surgery. There is another term which comes up here. You need to know what is the metabolic syndrome. And this is a new term, and actually metabolic syndrome consists of certain a combination of various diseases which occurs together in a person, and this combination is these five things actually. Visceral obesity, yeah, means truncal obesity. There is insulin resistance or diabetes. There is hypertension, and there is dyslipidemia, in which triglycerides are high and cholesterol HDL is low. So this is dyslipidemia, obesity, diabetes, and hypertension. This makes up a metabolic syndrome. Diabetes, hypertension, dyslipidemia, and combination with obesity is a metabolic syndrome. Actually, bariatric surgery can treat this metabolic syndrome. So that's why nowadays a lot of people, they are coming to surgeons for the treatment of their diabetes via a surgery. So this is called a metabolic surgery or diabetes surgery, because these bariatric operations, they have a marked effect on diabetes and metabolic syndrome, and actually that effect is more important than weight loss itself. And type 2 diabetes improves a lot, and patient actually may not need any medication for type 2 diabetes. So surgery is actually cost effective as well, because you stop all the medication, and glycemic control is much better without any medication. So in other words, you can say you can cure diabetes, type 2 diabetes, by bariatric surgery in certain patients. So this is called metabolic surgery as well. So now we come to the surgical treatment of obesity. What are the indications and what are different type of operations? Previously, it is an old slide of indication of uh, patients who are candidate for bariatric surgery, and it used to say that age should be between 18 and 55, and BMI of the person should be more than equal to or more than 40. That means morbid obesity. Or BMI can be between 35 to 40, that is class 2 obesity. But if patient has got high risk health problems or metabolic syndrome or coronary artery disease or all these things, or obesity induced physical problems like osteoarthritis, knee pain, and sleep apnea syndrome, all these things. So previous indications were these two: BMI more than 40 or BMI between 35 to 40 with comorbidities, and the age of the patient should have been between 18 and 55. But this was modified recently, and now the new indications, actually we have added a lot of other things. So it is the bariatric surgery is treatment option for anyone with BMI more than 40. It is the treatment option of choice for any adult with BMI more than 50. It is the option of choice in 50, treatment option more for 40, and you can offer a quick expedited assessment for people with BMI more than 35 with onset of type 2 diabetes. Similarly, assessment of the people even with BMI less than 35, 30 to 34.9, that is class 1 obesity, is also included. The patient has got type 2 diabetes within last 10 years. Also, in the Asian population, we are prone to type 2 diabetes and hypertension and coronary artery disease more than the Western people. So in this condition, if there is a recent onset of type 2 diabetes at the lower BMI, then even then we can assess these people for bariatric surgery. So if you see for us, actually for type 2 diabetes, BMI of more than 25 or around 30 can also be assessed for bariatric surgery. If more than 30 to 35, and with type 2 diabetes, it is also a candidate. You can assess it. If it is more than 35, definitely you should quickly or urgently assess this patient. More than 40 is definitely a treatment option. More than 50, it is the treatment of choice. So these are the modified or new indications, which are actually quite different from the old one. So what are different operative procedure? What you would offer to the patient? There are actually three types of procedure, or actually two procedures, and you can combine them together and making it a third type of procedure. So either procedures are classified as it can be a restrictive operation, restrictive procedures, It can be malabsorptive procedures or they can be combination of both. As the name suggests, restrictive procedure means you reduce the size or restrict the capacity of the stomach so that the person would not eat more than a certain amount, and that would reduce the capacity of the stomach. The other option could be malabsorptive procedure. You do some kind of surgery on the intestine so that whatever you eat is not absorbed properly, and because of that, the caloric intake is reduced. So this is the another option, malabsorptive. And third one, you can combine both of these together, and you can this can work better because it combines both of them. So there are certain different procedures for restrictive, different for malabsorptive, and different for combination of the procedures. But I've written only 3, 4 here. The commonest procedures are number one, the most common, one of the most common is banding. You apply a band around the stomach, and that reduces the capacity of the stomach. Or you can excise the stomach and make it just like a sleeve or a banana shaped stomach, making it a sleeve like, and these two will reduce the size of the stomach. Or you can do some kind of bypass or diversion of the small intestine so that the food is not digested properly. These are malabsorptive procedures. This is biliopancreatic diversion, or there is some modification in which you switch the duodenum as well from the pylorus. This is called duodenal switch modification of biliopancreatic diversion. And or you can combine the procedure in which you reduce the size of the stomach and do a bypass as well to divert the food stream. This is the combination. So these are the, so we call it band, bypass, and sleeve. These are the common band, bypass, and sleeve. Band, bypass, and sleeve. These are the common procedures. So we'll quickly just show the pictures of these procedures so that you can understand what is it. So if we just recapture the gastrointestinal system, starting from the esophagus, the cardiac end, stomach, duodenum, and then jejunum, ileum, and colon. So most of these procedures are either on the stomach for restriction of the size of the stomach or on the intestine for the malabsorption. So let's start with the first one, which is the common one and easier actually. It's called lap band. Another thing I forgot to mention, all these procedures can be done by an open operation, like you do a laparotomy and do an open surgery, or all these procedures can be done via laparoscopy. And the benefit of laparoscopy is that small holes, small incisions, and obese patient, they get out of bed quickly and they less chances of developing post-operative complications. Actually, nowadays, all the bariatric surgery is actually done by laparoscopy. So now, where were we? We were talking about different procedures. So let's start with the gastric banding. This is also called lap band, laparoscopic banding. It is also called adjustable laparoscopic gastric banding. A is adjustable, S for celastic, gastric banding. Or you can remember lap band, or just banding is okay. So if you see the picture, you can understand what is actually happening is just below the cardiac end of the stomach, where this esophagus is opening into the stomach, we make a very small pouch of the stomach, and just about 1 ounce or half a cup of the capacity of the stomach is left. And then below that, there is a band applied all around the stomach, which is actually encircling the stomach like this. And whenever patient tries to eat something, it fills very quickly, this band, with half a glass of water or milk, and the person cannot eat more. And slowly, this opening is very small, and this, whatever is there in the stomach pouch, it leaks or goes down slowly into the remaining stomach and then goes down. So actually, you have restricted the size of the stomach by applying the band all around it. This band has got a balloon, adjustable celastic balloon in it. And this a long tunnel or cable-like thing is going, and it is placed just deep to the skin in the subcutaneous plane on the in the umbilical or epigastric area. And from here, this balloon can be inflated or deflated if it is required. If you feel that it's too tight and patient is developing a lot of regurgitation and difficulty in eating, it can be deflated. Or if it is too wide and there is a person is eating a lot and not having any trouble, it can be inflated to make it tighter. So this is the benefit. Can be adjusted via reservoir under the skin. And actually there is no resection of the stomach or any structure is done, just applying a band. And the biggest benefit is that it is a reversible procedure. If person does not like it, you can actually remove it and the stomach will come back to its normal shape and the person can be back to normal. And there is very little vitamin deficiency and mineral deficiency because all of the stomach is there and there is vitamin B12, intrinsic factor, and all these things are there. But the disadvantage is that average weight loss is not that much, which person sometimes wants. It is only 25 to 30% of weight loss, excess weight loss is achieved. So, but this is easier. It is kind of a day procedure. The patient can come on the same day, can be discharged on the same day, and no cutting, reversible, lot of benefits. So this is one procedure. This is quite famous and common, lap band. It is being done in Lahore. Next restrictive procedure is you do a sleeve. It is called a sleeve gastrectomy, in which actually what we have done is that the stomach, big stomach, is actually cut and removed out of the body via a laparoscopic procedure. And a very small sleeve-like stomach is left near the lesser curvature. And it is just like a banana shape. And almost 4/5 of the capacity of the stomach is reduced. It is only one fourth, even less than that, 1/5 of the stomach is left behind. And around 80% of the stomach is removed. This is a new procedure, relatively new procedure, and it is getting popular among the surgeons. But the disadvantage is that it is a non-reversible procedure. Once stomach is removed, you cannot place it back. And if person wants it back, it cannot be done. So this has to be told to the person that this is not a reversible option. The second disadvantage is when you remove so much of the stomach, the intrinsic factor, vitamin and iron deficiencies and all these things can occur in this patient because the rest of the stomach is removed and patient will develop vitamin deficiency. So patient would need lifelong vitamins. But the benefit is that very good weight loss in this patient, and around 50% of excess weight is like if somebody's weight is around 80 and he wants to bring it down to 60 and excess weight is 20 kg, can be easily achieved by this sleeve gastrectomy. And the rest of the intestine is not touched. It is only the stomach which is excised. This is called sleeve gastrectomy. So first one is the band, second one is the sleeve. These two are the restrictive procedures. Now we come to the next procedure. This is bypass. So these three are the common procedure: band, sleeve, and bypass. Another we call it band, bypass, and sleeve. So in this, if you see, this is little complicated. In this, what is done is that the stomach is divided and stapled just below the esophageal opening, and a small pouch of the stomach is left attached to the esophagus. This is a very small pouch, just like a band, lab band size of pouch, and it is stapled, so it is closed. And the rest of the stomach is still there, and it is the pylorus and the duodenum and everything. Now, what is done is how food will go down into the intestine is that the intestine is divided here in the proximal part of the jejunum, and a root limb of the intestine is brought up distal end, and it is joined here with the stomach. So stomach pouch joined with the intestinal pouch, intestinal limb. So this is a Ru and Y. This is called Ru and Y because it is like Y shape. This is the common limb. This is one limb of the Y, and this is the second limb of the Y. And Ru is actually the name of the surgeon who first started it. It is a French surgeon. So again, what we have done is that we divided the stomach just below the fundus in this area, made a very small pouch of the proximal stomach. Then we divided intestine, jejunum near the duodenojejunal junction, and the distal part is brought up and joined to the stomach. And so what will happen? And this remaining, the duodenum and jejunum is joined to this same part here. So what will happen? You will eat something and it will go here, and straight away it will go down into the jejunum. And rest of the stomach is still there, but it is not participating, and it is restricting the capacity of the stomach. Plus, it is also bypassing the stomach, and the pyloric end is intact. And because the bile is coming from here, pancreatic juices are coming from here, gastric juices coming from here, it is joining the main food stream in the proximal jejunum. So this is how it is done. It can reduce a lot of weight. More than 50% of the weight is reduced. It is the combination of the two procedures. Bypass is also done, and the sleeve gastrectomy type of restrictive procedure is also done. And so weight loss is more, but it is a difficult procedure to be done. If you see here, there are three staple lines. One is here, the other one is here, the other one is here, three suture lines, and then dissection and bleeding, and also both complications of the restriction and the bypass can occur, leak of the suture line, bleeding, and all these things. So relatively difficult procedure, takes longer time, but weight loss is more. It is not the first line of operation nowadays. Sleeve gastrectomy or banding is done as a first line. Okay, so now this is purely a bypass. This is called biliopancreatic diversion with duodenal switch, in which what is done is little bit of stomach is excised, but mainly half of the stomach is still there. And then the stomach is divided at the pylorus, and the duodenum is coming like this. And then in the terminal ileum, it is divided, terminal ileum, and the distal terminal ileum is brought up and joined at the pylorus with the stomach. This is a new duodenum actually. So duodenum is switched. The terminal ileum comes up and becomes the duodenum, and the main duodenum is still there, but it is only acting as a drainage for the bile and the pancreatic juice. So duodenum is switched to the terminal ileum, and now it has got three limbs actually, if you know. One segment is the stomach and the new duodenum going down. The other segment, this is the main food line. This is the alimentary track. The other channel is biliary pancreatic channel, which is actually duodenum, and bile and pancreatic juices are coming, and it's coming down, 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 down. And these two channels join near the ileocecal valve, and they form a common channel. So in this, all of this intestine is actually bypassed, and food directly lands into the terminal ileum and goes out. And it is only mixed in this area with the bile and pancreatic juice. So very little digestion is done. Mainly it's kind of a malabsorption syndrome occurs, but a lot of weight is lost. But there are associated problems which are there for malabsorption. It's quite common here, but weight loss is quite a lot. And it is reserved for those who have got very super obesity, like more than 50 BMI, or previous surgeries, other operations are failed. So in that, this can be done. And difficult to tolerate actually. So these are the four common procedures. I will tell you again: lap band, sleeve, bypass, and BPD, biliopancreatic diversion with duodenal switch. So if we compare these four procedures in terms of malabsorption, protein and calorie malabsorption, excess weight loss after 3 years, and diabetes, effect on the diabetes after 3 years. So gastric band has got no malabsorption, Gastric bypass has got no malabsorption because these are restrictive procedures. Sleeve gastrectomy is also kind of a restrictive procedure, so no protein calorie malabsorption. But this biliopancreatic diversion has got a lot of protein calorie malabsorption. 3-year excess weight loss percentage, if you see, it is in gastric bending around 40, gastric bypass 50 to 60, sleeve gastrectomy 50 to 60, but this biliopancreatic diversion is around 70 to 80%. Same is diabetes. This biliopancreatic diversion, 80% uh, people, they will have cure of the diabetes. It is remission of the diabetes, but in these 50%. So they actually act good on the metabolic syndrome as well. So now we just quickly touch on to the complications of these complications. If you see for 3 different procedures I have done, gastric band, actually very little complications. Early you can only have DVT and pulmonary embolism, which is actually present in all these operations because patients are obese and super obese. So DVT and pulmonary embolism is the leading cause of death in these patients. And port infection in the band infection, tube may be leaked, tube may be loose, tube may be tight. It can erode into the stomach, or sometimes there is failure of the weight loss, and there may be weight gain as well. So these are the complications. They are not very life-threatening complications. But if you look at the gastric bypass, you will see anastomotic leakage, intra-abdominal bleeding, intestinal obstruction. They are very serious complications, all of these. And of course, DVT and pulmonary embolism is there. And late complications can be internal herniation, pain, bypass, stricture, and maybe weight regain. Similarly, in sleeve gastrectomy, again, leak at the angle of His is quite high, 2 to 3%. And then again, intra-abdominal bleeding, 2 to 3%. When you excise a lot of stomach, it can bleed a lot. And then gastroesophageal reflux and weight gain. Plus, DVT and pulmonary embolism are the complications which are common in all. So if we see the complication of biliopancreatic diversion and duodenal switch, you will see malnutrition, anemia, neuropathy. This is also vitamin deficiency, vitamin D deficiency, calcium, vitamin D problems, nausea, vomiting, dumping syndrome. So these are mainly malabsorptive procedures in the duodenal switch and biliopancreatic diversion. Gastric bypass complication, I think we have already talked about. So there are a few general complications as well. Post-operative depression is also one common thing because person wants to eat something and they are unable to eat. And there are other psychiatric and social problems with the person. So need to have a psychiatrist involved in this and dietitian involved in this. Temporary hair loss and malnutrition, but it gets better. Plus, when you lose a lot of weight, you will have hanging skin, excess skin. So sometimes they will need some kind of plastic surgery after the loss of fat from the body. So these are the 4 common procedures. Laparoscopic adjustable gastric band, this one, and the reservoir is under the skin. This is Roux-en-Y gastric bypass. Stomach is divided and a roux limb, and this is Y shape is attached. This is Roux-en-Y gastric bypass, and this is a sleeve gastrectomy in which this portion of the stomach is excised, and the main food channel, just like a banana, it is called sleeve gastrectomy. And these are the biliopancreatic diversion, in which if you make a new duodenum, this is called with biliopancreatic diversion. If you don't make a new duodenum and you join the terminal ileum to stomach directly, not on the pylorus, it is biliopancreatic diversion. These are the different types of procedures. So actually these 4, this one is one or the same thing. Only difference is that the distal limb is joined on the stomach or distal limb is joined on the duodenal area, pylorus. So next, this is again the same picture, 4 here. So you see here, this is band, this is sleeve, this is bypass. So band, sleeve, this is bypass, and this is biliopancreatic diversion with duodenal switch. New duodenum is formed. This is the old duodenum. So this ends, and we reached up to the conclusion. I think what I would conclude is that bariatric surgery is a very effective mean to achieve clinically significant and permanent weight loss with a low rate of complication. It results in significant improvement in multiple health issues which are associated with obesity, like metabolic syndrome, diabetes, hypertension, ischemic heart disease, certain cancers. And it definitely increases lifespan of the person. And it is also cost effective and it can be done laparoscopically. So that ends our topic of discussion today. And if you want to ask questions, I am available. I'm here to answer. Hello. Want to ask any questions? You can write in the chat. I think that's easier because I can't open the mic for you, everyone.